we encourage you to subscribe to MedSearch Moments wherever you listen to podcasts.
Do you have plans September 12th through 14th?
The AMSN Annual Convention is the can't-miss event for medical surgical nurses.
Register now to join AMSN in Toronto, September 12th through 14th, 2024.
And prepare to connect with hundreds of peers for 3 days of learning, the latest insights, trends, and best practices in the specialty.
Visit amsn.org to secure your spot.
On this episode of MedSearch Moments,
I've seen patients that are completely abusive, physical and verbal. I've had that kind of patient before where they get to their boiling point and it turns physical. We had a patient, it wasn't my patient, he set the room on fire. This is Eric.
Mary Tess.
Sydney.
Sam.
Neo.
and Laura. Welcome to MedSearch Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud MedSurg nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey. Our topic today is how to deal with that patient. But before we get started, how about some personal updates?
Sure, I'll kick us off with some personal updates. At work, we are working on implementing a new PCA pump, an epidural pump. So that's always exciting in the nursing education world when we've got new technology out there to train a bunch of nurses on and make sure they've got the resources that they need, some extra rounding. So that's been a fun project, partnering with some of my colleagues on that. Personal updates, not a ton. We're still adjusting to life being parents. My husband is gearing up to go back to work in the next few weeks as well. So now, just as we've gotten into a new routine, we have a brand new one to get going. So lots of learning there as new parents. But other than that, things have been delightfully uneventful. You don't need anything else at the moment. Sydney, what's going on with you? I know you're getting ready to move soon.
Yeah, still just getting everything set to move. At work, we're gearing up for one of my, side jobs, call them collaterals. One of my collaterals here at my hospital is the suicide prevention coordinator. So September is Suicide Prevention Month. So we're gearing up for that, planning some events here at my hospital. The biggest thing is going to be we're hosting a residency fair in our courtyard. So we're partnering with the USO, MWR. We're going to have Red Cross bringing their therapy dogs, some financial counselors, some different organizations from all over the base to kind of come out and show people their resources and things to have a more balanced lifestyle, which I guess would have been a good topic to talk about last week with our nurse wellness. But that's what's going on with me, just trying to get all that organized, get everything approved, and count how many tables and chairs and things we need for stuff like that. So that's all that's going on with me. Eric, how's it going since your last surgery? I know you said last week you didn't want everything to be about your surgery, but I'm so interested in your leg now all the time. It's all I think about.
Everything's going great. I just keep working out on it, trying to get that mobility back up. I've been trying to get that passport situation sorted out. I feel like I needed an adult in my life. How come no one told me it was so difficult to get a passport?
I've been putting off getting a new passport too. Mine expired not very long after I got married. So I was like, well, I'll wait till I change my name. And now my name's changed. And now I still haven't done it. And probably not going to until I have a trip actually planned where I have to, because that's who I am as a person.
I feel like I spent the last couple of days on the phone nonstop, just trying to get it sorted out. Been dealing with some heat over here in California, a little warmer than we're used to, and just trying to take it easy. Laura, how about you?
I hope you get that passport thing ironed out. We really want to have you with us in Toronto for the AMSN convention. With me, everything's going well. At work, they are encouraging everyone to submit abstracts to the Nursing Professional Development Conference for next year. So spent most of my weekend working on that, and I was able to hit submit on my proposal this afternoon. So yay for me. And on a personal note, my daughter is moving from her current apartment to an off-campus apartment to start and hopefully finish college this year for her senior year. So y'all pray for me. Keep your fingers crossed. We're almost to the finish line with her and her bachelor's degree.
Wow, congratulations.
That's so exciting.
What's her major?
Psychology.
Very interesting. Wish you all the best. Why don't we move on to our topic, how to deal with that patient? Who would like to get the conversation started? I'll do it, Eric. Thank you. Well, when we talk about that patient, I feel like we should clarify. What do we mean when we say, quote unquote, that patient? Do we all think the same thing? Are we all?
I think we do.
So I've seen many different approaches to it. I try to take the more inclusive approach personally. I just try to be very open with them. When I mentor or when I precept, I always say, pick your battles. Because when you have that kind of patient, it always seems like everything is a battle. I don't want to say that I let them get away with more than I normally would, but I mean, like, do you really want to fight about every single thing? You don't know what someone else's struggle is right now, and you just have to be open to that. And I try not to take anything personal.
No, I think that's a good place to start. I always think about being in the hospital. Most people don't plan to be there, right? Like some sort of acute illness, something tragic has happened, or just being in the hospital throws your whole life out of whack. And now you're here and we're telling you when you can eat, when you can't get out of bed without somebody here, even to go to the bathroom. You can't go to the bathroom by yourself because we don't want you to fall. It just goes on and on and on and on. And some people just really, really struggle not having any sort of control. To be able to recognize that from the nursing side, I think is really important. And being able to sit down and have some conversations and doing your best to allow them choices wherever they have them can be a helpful strategy for certain types of patients that are really struggling in interacting well and respectfully with their nursing staff.
I've never been in a hospital. After my surgery, I see it differently now. I mean, it's such an eye-opener. To be so nauseous and my Zofran is like 4 feet away from me, like I can see it, but I can't get it. And you feel completely powerless. And when you have to ask permission or ask for help for every single little thing you do, I feel real compassion. And I can't wait to take some of these new things back to my patients, because I always thought, oh, I understand what you're going through, because I genuinely tried to understand because I read the textbook and I've seen the TV shows. I watch Grey's Anatomy, I know what it's like, but when you actually are sick, it's so different. It's such an eye-opener. I felt so vulnerable and stripped and just at everyone's mercy. And it was more of a battle with myself also, being like, I have to give up the ghost and I have to give it up to a higher being to get me through it. And it's such a battle. I know we're talking about that patient and it turns out I'm that patient.
It's going to make you such a different nurse. It's going to make you a better nurse. You're going to have a way better connection with your patients now that you've had that experience.
Yeah. Now I can't wait for a UTI. No, just kidding.
Oh my goodness. One thing that I have found helpful when dealing with what I consider that patient, it's the patient that you can't please. Like, it doesn't matter what you do or what every other nurse before you has done, they're not going to be happy. And what I try to do is I try to get on their level. I will get a chair. I'll come over and I'll sit with them. And we have a talk about what are your expectations? What are they expecting to happen? Because sometimes they have unrealistic expectations or they have no idea how things operate in a hospital. So whether the nurses before weren't communicating that or they just didn't quite understand how things work, because we can't just snap our fingers and instantly have a doctor appear or make the surgery schedule match what we want. Things happen on a timetable and we have to be patient, but we understand how that works, but they may not. So let's sit down, let's have a talk about what exactly do they want? And let's take it step by step and let's give them back. Like Samantha says, give them some of that control back. Let them know what they have control over. Let them know what we have control over. And let's make a plan on how we're going to deal with the rest.
Yeah, it's like full transparency. That's the main patient we always do bedside report on. Because you'll get that patient who will try to pit the AM nurse against the PM nurse or say, well, hey, Laura said Dr. Smith was coming in at 7:30. So we are very transparent.
Yeah, I think listening to these stories, the other thing that comes to mind too is boundaries, setting them early and staying consistent. And that is where that bedside shift report can be really impactful. And honestly, just effective communication amongst the entire unit, whoever's working. This is what we've worked on. This is what we've agreed upon. We need everybody to uphold that so that we can maintain mutual respect and avoid clinical violence situations and things from escalating severely.
Yes, and that's exactly what I was going to say with setting boundaries. Whether they don't know how things go or they're trying to see what they can get away with as far as what the nurses will do for them. I had a patient one time, I was charged. We didn't keep Coke on the floor. All we had in the fridge was ginger ale. And this one patient, all she had to do was dial the phone to call the cafeteria and they would bring her a Coke. And she refused to call herself. And she wanted one of us to dial 3 numbers on the phone just to get her a Coke. And it's like, I can't take time out of my day to do something that you can do completely for yourself. Because she definitely understood that she could do it herself. She just didn't want to. And then she got furious that we weren't doing this thing for her. And so setting that boundary of what my job is and what the expectations are as a patient even. Some people don't know how to be a patient. So letting them know the things that I expect you to do for yourself when you can do them. That patient is tough.
Yeah, especially when you're trying to get them ready to go home and you know what they're going to have to deal with when they go home. Like, I know it hurts to get up and walk, but we have to get up and walk. There's no way you're going to be able to go home if you cannot do X, Y, and Z. So I know it hurts, but let's make a plan. When do you want to get up and walk? So one way to give them control is to let them decide when they're going to do what you have asked them to do. It's not if you're going to do it, it's when are you going to do it. So let's give them a little bit of control that way.
We call that opt-in language. So not if, but when. Yeah, exactly what you just said. And sometimes too, it's even just the timing of things can be a really simple thing to work with them on. Like maybe they've been totally stable for a while and they are tired of being woken up for vitals overnight. So, okay, great. Let me work with the provider and see, can we skip your midnight vitals or only do them every 8 hours instead of every 4? Or when you like to eat your meals or at home, do you always shower in the evening? Those open dialogue conversations can be really effective in coming up with a good plan and give your patient a little bit of that control back while they're under your care.
Another thing is to share that information with the rest of your team. Write it on that whiteboard or make sure it's in the chart or talk about it when you're in bedside shift report. Just because you took the extra time to find out that little piece of information that the patient gives doesn't mean the rest of the staff is going to ask that same question. So if you earn a little nugget of information about what the patient's like, share that with the rest of the team.
I feel like there's also times where you will have them have a little too much control. And I feel like sometimes you get that from the administration side of nursing. At least for our hospital, sometimes we have patients that are very much in control. And I feel like at times we create that kind of patient. We create that patient because we let them get away with so much. And I've seen patients that are completely abusive, physical and verbal. And administration's answer to it is to go in there and speak with them and set up a contract, which I have never seen anything come from speaking or a contract, at least for me, for the hospitals I've been at. I
had a patient with a contract too.
Yeah.
Didn't do anything.
No, not at all. Contract. I will not throw my tray at the nurse. If I do, I will get another contract or I will be escorted. We have banners all over. They push this new anti-violence at our hospital. You can't speak negatively. You can't curse. You can't show any kind of violence towards the nursing or the staff, or you will be promptly removed from the hospital. It's like one of those old ancient scrolls. It's like you open, it's all dust covered and spider webs, because that has never occurred at our hospital. Everyone gets yelled at and thrown, and it has to be a unified front.
Yeah, that's why it's so important to keep everybody on the same page, because if one or two people break away and give them what they're looking for, you're going to start back at ground zero.
Yeah. And then, you do have some of those patients, I think it was Laura, said they're always going to be dissatisfied, that nothing is ever good enough, that no matter what you do, nothing is ever right. And at that point, what do you do?
To me, at that point, I'm just going to do my job. I'm going to protect my license. I'm going to document the heck out of everything. Just be respectful, but at some point, there's really not a lot you can do. I think about my years earlier on in practice, that would have gutted me. But as I'd been a nurse longer and longer, it's like, if you're going to be treating me this way, it's not worth my emotional energy to be hurt by it. I'm just going to do my job. I'm going to take really good care of you. And I'm still going to cross my T's, dot my I's, and make sure that you receive good care. But I was able to kind of put up that wall to not take it personally.
That's a skill I think nurses have to recognize, that you cannot please every single patient. I mean, I can remember being fired from a patient because I walked in with a bubbly personality and he's like, no, I cannot handle that, because I was too nice. And he literally asked for another nurse. I was devastated by that. Now that I've gotten older, I'm like, okay, cool. Let me go find somebody else for you. It's not a big deal.
That's when you give them that nurse.
Good point. Good point. Yeah. And that's a good point. There are nurses that are really, really good at dealing with patients that are difficult. You know, they know how to talk to them. They're very firm. They're very structured. And they know how to do what Sam just said. You don't let it bother you. You do your job to the best of your ability. They're not going to be happy, but there's nothing you can do about that.
Going back to our last episode, check in with those nurses and make sure that they're okay.
Good point. Good point. But also I want to say is that, I mean, that's one of the reasons that we have chain of command. So you do have to let your charge nurse know. And if they have any other ideas, then it's going to be on them to figure out what that next step is. And then that can go to management and so on up the chain. But that also ties into our last episode about a healthy work environment, because you don't want one of your leaders to come in there and set you up for failure by promising things to that patient that we can't deliver.
Here's another thick layer to the onion that I am. Those are my favorite patients. Is that disgusting?
No.
I love.
That does not surprise me one bit.
Whenever there's like a VIP at work or a difficult patient.
One of those patients.
Yeah, those are my specialty. I love them. I love it. I find it like a personal challenge. I say, oh, you think you're going to hate me? Give me 12 hours. I'll change your mind. And I love it.
I wish our listeners could see your sparkling smile so they would know. I can see how you get away with that.
Eric, I do kind of agree with you to a point, because the hospital that I'm at now, we don't typically get those patients, but every once in a while that we do, I miss it. I kind of miss the chaos. We had a patient a couple of months ago. Older gentleman had a UTI, so he wasn't in his normal state of mind. And he had somehow gotten into his patient belonging bag of his clothes that were covered in urine and started putting them on. What you doing? I'm going home and putting my clothes back on. Or like, oh, well, why are your clothes wet? I know why they're wet, but you know, this is how you talk to patients. He goes, 'cause I pissed in them. Well, okay. Yes, you did. All right, maybe let's put you in dry clothes. We found him a pair of scrubs and we just put him in those instead. And he was just happy to have pants on. Did he pee through those scrubs 100 times too? Yes. But, you know, it stopped him from getting out of bed to try to put pants on.
You just have to laugh.
But it's like that chaos of that one patient that is just giving you the toughest time. Like, stop trying to get out of bed to put your pants on. I don't have a dry pair of pants for you anymore. You're going through all the hospital scrubs. Please.
Sydney, at that point, it's kind of like frustrating and a challenge, but it's funny. Like you said, because you're like, look what's going on. I'm fighting someone who keeps trying to put on urine-soaked clothes and giving them all these scrubs. And
it's true, because I hadn't had a patient like that in so long, and I was just laughing, leaving the room like, oh, this sweet old man, this poor sweet man just wants to have a pair of pants on and he can't. And you find a way to deal with that patient that's just giving you the runaround, giving you a hard time, and you just got to find a way to make it work.
you know,
Even if that solution only lasts until the next time they pee through the pants.
You buy yourself a little bit of time, though.
Exactly.
Make sure you take your lunch break.
Yep.
I have seen, when we talk about that patient, I've seen them interact with their families at the bedside. And there's two types. There's either the ones that pull a complete 180 and are angels and saints, and as soon as they leave, the horns come out, or they're just as nasty and mean to their family. You know,
Or when they pull the 180 when the doctor comes in the room.
Yes, yes.
I see it's all nodding and smiling. We've all been there. Yes.
Sometimes family's even harder. When this topic came up, I was thinking about some scenarios that really stuck in my head. And one was The family member would come out to the desk every single time the patient needed something, but it was like a 911 emergency for the tiniest little things. So much reiteration of, I will get there when I can. I understand, I'm trying to explain all these things. And it just like never, ever got through to them. So at the end of that day, I fired myself and I told the charge nurse, I first had said, I don't want that patient back tomorrow. I can't do another day, which is totally fine to do. I said, I can't do another day. And then truly by the end of it, like after report and everything, the family member was extremely unhappy with me. I said, I will take a whole new assignment tomorrow on the other end of the floor. I got as far away from that patient and family as I possibly could for my own mental wellness. I just knew there's no way I could handle that another day without having some sort of emotional outburst myself, because it was just all day long with no break whatsoever from this verbal violence that I had been going through the whole day.
That family can be more trouble than that patient because they're so concerned over their loved one, or they don't understand what's going on because they're not there all the time. And so they feel like they're missing out, or they feel like things are being done without their knowledge. And it can be really hard to educate those family members on the status of their family or what's the plan, what's happening going forward. That's the only thing that they can do to help is like, oh, I need to get them these ice chips right now.
Right.
Yeah.
Like, well, that's not my priority right now. So.
Right. And I think I tried everything to explain and talk and spend time and all these things, and it just never worked. And the nurse's word was never good enough. It has to be the doctor's. It just went on and on and on. So I was like, I'm done.
That's protecting yourself. You got to put the life vest on yourself before you help others. And that leads to last week, our topic last week about self-preservation. I don't have trouble saying no and sticking up for myself. At first, in the beginning, when I first started, I kind of felt like if I gave away a team that was difficult, it almost reflected on me. I felt kind of like a failure. Like I thought, oh, I can't take care of them. But you have to look out for yourself to protect yourself from that kind of environment. And you're right. Sometimes the families can either help or hinder. I've had family members come out saying, they need pain meds. And you ask the patient and they're like, I don't need anything. Or they'll sneak their NPO patient the ice chips.
Or the takeout bag. I had a teenage patient. He might have been like 19. I live in a college town, so there's a college nearby. I think he had pancreatitis. He was going for surgery the next day, but she didn't know that. And he called her and said that we were starving him and not letting him eat. So she brought him a takeout bag of fast food. He'd gone downstairs and ate with her in her car and then came back up to the room. A few hours later, he was writhing in pain, and then he had to come clean with me.
Wow. I've also realized that no matter what you do for that patient, they're never going to want your assistance or help. And that's okay. And sometimes you're going to have to ask for help from another nurse. I've seen it before where they will not take your advice, but they'll take the advice of a nurse who says the exact same thing you do. And sometimes it's okay to just walk away from that, to be reassigned from that patient. Sometimes you just don't click. And you have to be able to say, are you going to try for the next 12 hours to struggle and fight and try to do this or the next shift, or just be okay with giving it away and having someone else take it over? Like Samantha was saying, you would come back and you would take a new assignment. You just didn't want to have that patient. And maybe that patient did better with someone else.
Yeah, probably throughout that shift, you've been keeping in contact with your charge nurse and letting them know about the struggles you've been having. So it's not going to be a surprise when you go to the charge nurse and you say, I'm back tomorrow, but I would prefer not to have that patient. I've just had a rough day with them. I don't think I'm going to be able to get through to them. I think it'll be better to give somebody else a chance.
I agree. But I will tell you guys this. Give it one more shot. Find the most difficult patient.
See it as a challenge.
I just like the thrill of it for those long shifts. Laura, maybe your daughter can give us some insight when she graduates.
So what's wrong with you?
What's wrong? You're doing an evaluation on Eric.
I'll have her do that. She can also read your tarot cards if you'd like her to do that.
Ooh, I like that.
That'd be a good episode. Just have us all get our tarot readings.
I've had that kind of patient before where they get to their boiling point and it turns physical. We had a patient, it wasn't my patient, he set the room on fire. He got his little lighter, like the little butane ones, and closed the door. He was NPO and it was during lunchtime and they wouldn't pass him a tray. So he slammed the door shut and pulled out his butane lighter and set the mattress on fire.
We had one patient that was swinging his IV pole that had a bag of TPN hanging from it because he was NPO. This nurse was like maybe 5 feet on a good day, ducking punches and like this bag of TPN that's like swinging from this IV pole.
Code rush on our department.
Yep.
Yeah, I just feel like I said, you just have to always be aware of what's going on with those kind of patients, because you never know when it can flip, when it can switch on you. That's why I think also it's important, like Laura said, keep the lines of communication open with your charge nurse.
And don't put yourself in harm's way.
Yeah.
Don't be ducking from the pole. Get the heck away from the pole that is swinging.
Yeah,
Get out of there. Yeah.
They teach that way, teaching crisis prevention. And one of the things they recognize is those early signs. We miss them so often because we think it's just normal behavior, but it may not be normal behavior for the patient. So
we used to have just a verbal de-escalation class at my organization, but now it also has an emphasis on situational awareness and looking for those signs of things that are going to be happening and trying to be more proactive in that regard, because they were finding event after event after event. It was like, it seemed obvious to other people looking in, like we missed like 3 red flags before we got to this point. So now we're trying to teach people how to see those red flags a lot earlier on.
I think nurses anticipate that we're going to be abused and beat up during a shift, and we have to say, no, that's not okay. It's not okay to be ducking and covering or bobbing and weaving like Muhammad Ali when you go into a room. You know, that's not.
Yeah, there's a TikTok that I've seen it happen. People are like, okay, I'm a real nurse now because I just got punched by a patient. Well, no.
Yeah.
No, we need to stop
That shouldn't be
celebrating.
the culture, and that shouldn't
We
be
need to
the
stop
norm.
celebrating it. Yes.
Yeah. I mean, like, could you imagine being an accountant and being like, oh, I didn't get hit with a fax machine? Why is it our profession that physical violence is okay? Oh, I feel like we can go on and on and on. But before we go, let's quickly summarize what we've learned. Put yourself in your patient's shoes and remember, they're feeling vulnerable and powerless in their inability to take care of themselves. Determine how you can give some of the control back, such as working out a plan for the things they need to do before they are discharged. Set boundaries early and remain consistent with plenty of effective communication regularly. Be sure and share information about the difficult patient with the rest of the team. For the patient who cannot be pleased, no matter how hard you try, keep detailed documentation, and above all, do not take it personal. Also, make sure your charge nurse knows. Sometimes difficult patients respond better to nurses who are tougher rather than nicer. If all else fails and you've absolutely reached the end of your rope, ask for help or a new assignment. At the end of the day, you have to protect yourself. Don't feel bad. Maybe the patient just needs a fresh nurse. To our listeners, thanks for joining us. We'll see you next time.
We look forward to connecting with you on the next episode of MedSurg Moments, the AMSN podcast.
In the meantime, we encourage you to subscribe to MedSurg Moments wherever you listen to podcasts.
To reach us, use hashtag MedSurgMoments on your social posts.
Or send us an email at amsnpod@amsn.org. That's amsnpod@amsn.org.
We're all AMSN members, and if you love MedSurg Moments, we invite you to become a member of AMSN. You can learn more at www.amsn.org.
Finally, the content within the MedSurg Moments podcast represents the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses.
Until next time, this is Eric.
Laura.
Mary Tess.
Neil.
Sam?
And Sydney. And always remember, MedSurg Moments is a moment in our lives and a moment in our MedSurg careers that makes a huge difference.